So we have now about 10 minutes for questions and answers before we have a 30-minute lunch break, because we want to start with the workshops on time. So questions, maybe I can start off with Mr. Tony.
Thank you. So, I'm Tony Redmond. I'm chair of the Health Professionals Standing Committee. My question really is to all three of you, and it is, in terms of reducing inappropriate variation in patient care, it's clearly helpful to have mobility, because that helps to smooth out these variations that are cultural. But certainly hearing the first two presentations, it strikes me that healthcare professional mobility is driven as much by economic factors and political factors as it is by a desire to improve patient care or a desire to change cultures. So could you give me an insight as someone who's championing the cause of increased mobility into the relative proportion of those two effects?
I think that's, in the first place, I think that's the correct observation, because there is a bit of a conflict of policy goals. In the EU law, it's a citizens' right, you know, that you can go to another country and search for employment. So it's the individual, and the individual is not mandated to think about the health system. But if you look from the regulator's place, or from health policy makers, or from WHO has a global code on the ethical recruitment of international health personnel, and all countries actually try to adhere to it. It's a completely different perspective. It's the country and the health system's perspective, and a little bit the patient's perspective as well. So how can we reconcile this? Shall we give up the individual freedom, or shall we give up health system? I think none of them we can give up. We need to find a way in between. And with our policy brief, we have listed a couple of policy options. How can we actually develop a little bit better our workforce? Because people are also leaving for good reasons. You know, in countries where you have excessive outflows, there's something really going wrong. And where you have excessive inflows, something is going wrong as well.
And maybe a way to change the way how health professionals are treated. Because that's what I learned from I think from the Czech colleagues, because there were some threats on their system, and they said, okay, if you're going to impose this on us, we're all going to leave to Germany and Austria and so on. And finally, they didn't do it. So there is something the health professionals can do it as well. Any other comments from your sides on that question?
Well, I think that if you look at the minimum training requirements, the fact that we've managed to update them, I think that contributes to patient safety. There are quite a lot of things that we managed to obtain. One of which, just to take an example, the minimum amount of general education that midwives were required to do before they started the midwifery training used to be 10 years. So, i.e., it could have been a vocational training. We managed to change that to 12 years, and that will take effect in January. So those kind of changes, I think, help toward, you know, producing better quality professionals across Europe. And I think that, you know, that contributes to patient safety in general.
With regard to the education of the non-physician health professionals at Thea, we have, for the physicians, we have EUAMS, which I think is extremely helpful in informing us what let's say, for instance, a rheumatologist should know. And so that has been implemented, I guess, in all the member states of EUAMS. Do we have similar instruments or tools for health professionals, so that, let's say, the education of a occupational therapist in Germany is close to the one in Portugal? And if not, what can we do to help here?
No, there is not yet an international standard for the postgraduate education, and even with many health professions, that even within the basic training there is already a large diversity. And in our survey it was clearly stipulated by many respondents that there was a need for more standardization of the postgraduate education.
So this is something where EULAR could probably at least help in order to. Are there any thoughts on the EU level to take care of this as well?
Yeah, I think increasingly thoughts on the EU level, because what we are talking now is the skill mix actually, and I was very glad to see that you have included all the professions helping there, and actually the patient needs to be included. And at the moment, you know, we have a very, as far as we know, extremely diverse skill mix. Only if we look into the numbers of doctors and nurses and the ratios between, it's unbelievable. And in positive terms, you could say this is a laboratory for seeing what works. In negative terms, you must say some of this just cannot work, cannot be efficient. And I think we need to have much more thorough research on the skill mix, not only doctor or nurses, but the whole teams in complex care and care for multimorbidities.
Thank you. There is a question to the right.
Thank you. Paul van Hoof, working for GSK. A couple of years ago, also one of the co-founders of the Central and Eastern European Health Policy Network. With that network, we drafted some scenarios how healthcare systems in Central and Eastern Europe could evolve. And the key trigger actually in all 4 scenarios that we drafted was the lack of good quality healthcare professionals. And that was an overhaul triggered an overhaul of those systems. So, and people living in those countries and the health policymakers there, they really see this as one of the biggest issues. And also, I think if you would ask the ministers of health. So my question to all of you is, how big is this going to be? How big is the issue truly? And certainly in those countries from your experience and your research.
Who wants to start?
Can I just ask you to clarify? Is it a lack? Are you talking about the brain drain, or are you talking about the quality of the professionals?
No, just the lack of professionals itself, yeah.
Go for it, Matthias.
If we look into former Yugoslavia, we had the situation that actually what is today Serbia were serving most of Yugoslavia. They had overcapacities in comparison to the rest, and they were even exporting throughout the 1970s and 1980s large numbers of medical doctors towards Germany, the UK, Belgium, the Netherlands, and other places. Now, this has changed completely because of the war and the isolation, and also the technology change, and they couldn't keep pace with all this. And today, the Serbian medical education, which was believed to be excellent in the 1970s and early 80s, is substandard actually. And the problem now for the other regions in former Yugoslavia is that they don't actually have the capacities they need to build up. And some of these areas, they also developed funny ideas like giving medical education or giving nursing education into hands of private organizations, which were very difficult to regulate. Romania and Bulgaria, until recently, in terms of workforce development, were in a kind of stalemate. They didn't do anything, actually. The medical universities produced doctors, but there was no clear if there was demand for it, and the hospitals demanded doctors for which probably no new doctors were available. So it's a very difficult situation. Bulgaria is trying since the last 2 or 3 years to come up with political consensus, and Romania is just starting about this. So the situation is quite difficult in these countries. At the same time, they are trying to attract foreign students, you know, and they are training foreign students, so people who cannot get a training slot in their country because of numerous clauses, they can go to Romania and then come back, and that causes a lot of worries.
Okay, so thank you very much. So I just got the signal that we have to conclude this morning's session. So again,